last time we discussed about connections and functions of the basal ganglia. Today about diseases or lesions of the basal ganglia. The first disease of the basal ganglia is athetosis. Athetosis. Athetosis is a continuous, slow, writhing movement. Continuous, slow, writhing. W-R-I-T-H-I-N-G. Continuous, slow, writhing movements involving hand, arm, face, or neck. So, continuous, slow, writhing movements involving hand, arm, face, and neck. And what is the cause of this athetosis? The lesion is, the damage is in globus pallidus. So the damage is in globus pallidus. The next disease of the basal ganglia is hemiplegismus. Hemiplegismus. Hemiplegismus is sudden, violent movement involving one limb or half of the body, or one side of the body. So sudden, violent movement involving one limb or one side of the body. This is called hemiplegismus. Hemiplegismus. And where is the lesion or damage? The lesion is in the subthalamus nucleus. The lesion is in the subthalamus nucleus. The next disease related to the basal ganglia is chorea, or also called Huntington's chorea. Huntington's chorea. Huntington's chorea is a hereditary disease. It is hereditary disease which manifests at the age of 30 to 40 years. So hereditary disease which manifests at the age of 30 to 40 years. It is characterized by flicking or distortional movements, characterized by flicking or distortional movements affecting face, arm, or neck. Now in this chorea, Huntington's chorea, there is degeneration in the caudate and putamen. The degeneration in the caudate and putamen. Now in the connection of the basal ganglia, we discussed that nerve fibers passing from corpus striatum, the caudate putamen, to the globus pallidus and substantia nigra secrete GABA at the nerve endings. These secrete GABA at the nerve endings. Now when there is degeneration in the caudate and putamen, the release of GABA in globus pallidus and substantia nigra decreases. And we know GABA is an inhibitory neurotransmitter. GABA is an inhibitory neurotransmitter. So inhibition on globus pallidus and substantia nigra is lost. And due to loss of inhibition in the globus pallidus and substantia nigra, there are outbursts of impulses from the globus pallidus and substantia nigra, and this results into the flicking or distortional movements affecting parts of the body, right? So there is degeneration in the caudate and putamen. So release of nerve fibers which pass from the caudate putamen to globus pallidus and substantia nigra, these release GABA. So this release is decreased in the globus pallidus and substantia nigra, resulting into loss of inhibition in these two nuclei, the globus pallidus and substantia nigra. And result will be outburst of impulses from these two nuclei, resulting into the features of the Huntington's chorea. Now in chorea there is also dementia, loss of higher mental function, loss of higher mental functions, dementia. Now dementia is not due to degeneration of GABA secreting neurons in the caudate and putamen. Dementia is due to degeneration of acetylcholine releasing neurons in the cerebral cortex. So in the cerebral cortex, the neurons which are cholinergic, which release acetylcholine, these are degenerated. And this results into dementia, loss of higher mental functions. So keep in mind, dementia is not due to loss of GABA secreting neurons in the caudate putamen, but due to loss of damage to the cholinergic neurons in the cerebral cortex. I mentioned that chorea is hereditary disease. There is abnormal gene, and in this chorea, the codon CAG is repeated many times. So the codon CAG is repeated many times, and this results into formation of a protein. It results into formation of a protein which is called Huntington's. It is called Huntington's proteins, and that is deposited in the caudate and putamen. So neurons in the caudate putamen degenerate, release of GABA in the globus pallidus and substantia nigra is inhibited, decreases, and this results into the outburst of impulses from the globus pallidus and substantia nigra, resulting into features of this disease, the Huntington's chorea. Our next disease, which is common due to lesion in the basal ganglia, is Parkinson's disease. Parkinson's disease, or Parkinsonism, or Parkinsonism. Parkinson's disease or Parkinsonism. It is due to degeneration in pars compacta of substantia nigra. It is due to degeneration of neurons in pars compacta of the substantia nigra, resulting into deficiency of dopamine in the caudate and putamen. Resulting into deficiency of dopamine in the caudate and putamen. So degeneration in pars compacta of substantia nigra, resulting into deficiency of dopamine in the caudate and putamen. So we discussed that nigrostriate fibers release dopamine at their nerve endings. So fibers which pass from corpus striatum, caudate putamen to substantia nigra, right? So fibers which pass from substantia nigra to corpus striatum, the caudate putamen, these release dopamine. So fibers which pass from the substantia nigra to caudate putamen, these release dopamine. We know dopamine is an inhibitory neurotransmitter. Now in the caudate putamen, corticostriate fibers release acetylcholine. And we know acetylcholine is an excitatory neurotransmitter. So two types of neurotransmitters are released in the corpus striatum, caudate and putamen. Dopamine from nigrostriate fibers and acetylcholine from corticostriate fibers. Acetylcholine from corticostriate fibers. Now normally there is a balance between dopamine and acetylcholine. Is the balance between dopamine and acetylcholine. Now when there is deficiency of dopamine, the excitatory influence overrides in the caudate and putamen. And this results into features of the Parkinson disease. So deficiency of dopamine results into imbalance between dopamine and acetylcholine. Imbalance between inhibitory and excitatory neurotransmitter. And this results into features of the Parkinson disease. What are the causes of Parkinson disease? Many cases are idiopathic, without any known cause. Idiopathic. Idiopathic, without any known cause. It is thought that in old age, with the advancing age, the dopamine receptors and release of dopamine decreases. So with advancing age, the dopamine receptors and release of dopamine decrease. And this results into Parkinsonism, Parkinson disease. The other cause is trauma, injury. So injury or trauma to the basal ganglia, it results into the damage to substantia nigra and release of dopamine. Right? One famous example is the famous boxer Muhammad Ali. In the boxing, he had damage to the basal ganglia, and he is having the typical features of the Parkinson disease. Other causes as complication of influenza. As a complication of influenza. In First World War, there was epidemic of influenza, as there is a pandemic of coronavirus. So in First World War, there was epidemic of influenza. So as a complication of influenza, there was Parkinson disease. Parkinson disease was as a complication of influenza during First World War. Then this disease can be as a complication of treatment with phenothiazine derivatives. So as a complication of treatment with phenothiazine, derivatives. So when you use these drugs for a long period, it results into Parkinsonism, Parkinson disease. What are the features of Parkinson disease? There is akinesia. Akinesia. Difficulty to initiate movement. Difficulty to initiate movement. The patient is sitting, you ask him to stand and walk. The patient will take much longer time to stand and then to start walk. So difficulty to initiate movement, that is akinesia or hypokinesia. There is rigidity, lead pipe or cog wheel rigidity. Lead pipe or cog wheel. Lead pipe or cog wheel rigidity. Now lead pipe rigidity, you passively bend the arm of the patient. You feel just like bending a lead pipe. So you have got feeling of bending a lead pipe when you flex passively the arm of the patient. The lead pipe rigidity. Other is cog wheel rigidity. You flex the arm passively. There are intermittent resistance. There is intermittent resistance when you try to flex the arm. This is the cog wheel rigidity when there is intermittent resistance to the flexion of the arm. What is the cause of rigidity? Increased motor neuron discharge to both agonists and antagonists. Right? So increased motor neuron discharge to both agonists and antagonists. This results into rigidity, lead pipe or cog wheel rigidity. Because of rigidity, you see the patient, his back is flexed, knee are bent, arms are adducted and flexed, and patient is like a statue. So when he's asked to move, he moves like a statue. Right? Do you see in this figure? Back is bent, knees are bent, arms are flexed and adducted, right? And patient moves like a statue. You see in this figure also the patient of Parkinson disease. Right? Another very important feature in this disease is static tremors. tremors at rest. Tremors at rest. And tremors may involve hand, fingers, lips, or tongue. So tremors may involve hand, fingers, lips, or tongue. So tremors are present at rest, static tremors. And during voluntary activity, these decrease. So tremors decrease during voluntary actions or activity. Tremors also disappear during sleep. So during sleep, tremors disappear. But tremors become worse. Tremors become worse when patient is conscious that he is being watched. Right? So when patient is emotional or he is very conscious that he is being watched, then tremors become worse. So tremors become worse when patient is conscious, emotional, and he thinks that he is being watched, then tremors become worse. So these are static tremors, tremors at rest, which will decrease during activity, disappear during sleep, and become worse when patient is emotional or is conscious that he is being watched by others. Because of rigidity, tendon jerks are difficult to be elicited. Because of rigidity, tendon jerks are difficult to be elicited. Babinski sign is not present. Babinski sign is not present. This mask-like face because of loss of expression. So loss of expression on the face. No, the face there is no expression. So mask-like face is present in these patients due to loss of expression on the face. Associated movements are lost. Say, unconscious arm swinging during walking. Unconscious arm swinging during walking is lost. You see this patient, when this patient walks, no arm swinging during walking. Of course, it is unconscious arm swinging during walking. It is lost in these patients. When these patients, no paralysis, no sensory loss. So no sensory loss, no paralysis in these patients. Short-stepped, shuffling gait. Short-step, shuffling gait in these patients. Patient takes short steps and shuffling gait in these patients. I told you there is akinesia in these patients. Patient feels difficulty to initiate movement. But once he starts some movement, it is difficult to stop him also. Of course, there is akinesia, and when patient walking, also difficult to stop the patient. So these are the features of the Parkinson's disease or Parkinsonism. Few words about the treatment of this disease. In this disease, what is the cause? Deficiency of dopamine. So we give L-Dopa. We give L-Dopa, and L-Dopa has a remarkable beneficial effect on these patients. So L-Dopa, when given, has remarkable effect on the patient. L-Dopa can cross blood-brain barrier. L-DOPA can cross blood-brain barrier. In the brain, it's converted into dopamine. And this makes up deficiency of dopamine. So there is improvement by giving L-DOPA. Now here you can say, why not to give dopamine? Why to give L-DOPA, not dopamine? Dopamine, when given, cannot cross the blood-brain barrier. So dopamine cannot cross the blood-brain barrier, so it can't be given. Now, in addition, we can also give anticholinergic drugs. We can also give anticholinergic drugs because there is an excitatory effect by the acetylcholine. So we can reduce this effect by giving anticholinergic drug. We can give a synthetic dopamine agonist. Synthetic dopamine agonists such as bromocriptine. 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 This is a synthetic dopamine agonist. So by giving this, we can improve the patient. We can also give monoamine oxidase inhibitor. Monoamine oxidase inhibitor such as L-daprenil. So give L-daprenil, which is the monoamine oxidase inhibitor, and this can improve the patient. Now, in some cases, when there is no improvement by these drugs, then we can perform electrocoagulation of the thalamic nuclei. Electrocoagulation of the thalamic nuclei. You know, in the connections of the basal ganglia, all the feedback impulses to cerebral cortex from the basal ganglia, the feedback impulses to cerebral cortex, these pass through the thalamic nuclei. These pass through the thalamic nuclei, ventoanterior, ventrolateral, thalamic nuclei. So we destroy these nuclei by electrocoagulation. We destroy these nuclei by electrocoagulation, and this results into improvement in these patients. It leads to improvement in these patients that by the electrocoagulation of thalamic nuclei, ventoanterior, ventrolateral, thalamic nuclei. Nowadays, a new method is being employed to treat this disease, and that is transplantation of fetal dopamine cells. Transplantation of fetal dopamine cells into the brain of the patient. When there is abortion of the fetus, we take out dopamine cells from the fetus which has aborted, and these cells are transplanted into the brain of the patient. So these dopamine cells of the fetus, these secrete dopamine, and the patient has got improvement for months. So for months, these dopamine cells from the fetus can work to give improvement to these patients. So now this method is under research and is being employed in these patients. So this was about the treatment of the Parkinson disease. Another disease of the basal ganglia is Wilson disease. Wilson disease, also called hepatolenticular degeneration, also called hepatolenticular degeneration. So this Wilson disease is a genetic autosomal recessive disorder. Genetic autosomal recessive disorder in which there is low levels of ceruloplasmin. So levels of ceruloplasmin are low. The ceruloplasmin binds copper. When ceruloplasmin is low in the plasma, copper is deposited in the liver and also in the lenticular nucleus. So copper is deposited in the liver and the lenticular nucleus. And this results into hepatolenticular degeneration. There is a degeneration of the lenticular nucleus and also degeneration of the liver. And this leads to hepatic cirrhosis. It leads to hepatic cirrhosis. So in this disease, lenticular degeneration, and there is also hepatic cirrhosis. So this was about the Wilson disease or the hepatolenticular degeneration. And this was about the diseases of the basal ganglia. Thank you.